everyone to today's session. My name is George, and I'm going to take you through this session as the moderator. Now, we have an experienced presenter today uh, who is going to take us through an exciting topic. And the topic for today is quality cost analysis in clinical laboratories. So, this is a very critical area as far as medical laboratory practice is concerned. And our presenter today is Mr. Wekesa Davis, who is an experienced medical laboratory officer. And Mr. Wekesa works with Saba Lancet Kenya, renowned diagnostic laboratory that has a wide coverage in Kenya in terms of laboratory practice. And with that, I'd like to now give this chance to Mr. Wekesa to start us off and proceed. So, Mr. Wekesa, from where are you able to hear my voice?
Yes, Mr. George, I can hear you clearly. Am I audible enough?
Great, you are audible likewise. And so allow me to hand over this session to you now so that you can start your presentation. So feel welcome, Mr. Davis.
Thank you, Mr. George. I really appreciate this opportunity to be here today, and also to just appreciate our dear participants who are in this webinar today. It takes a lot to be here, so we really do not take it for granted. And as I've been introduced, my name is Wekesa Davis. I work with Saba Lancet Kenya Limited as currently as a laboratory manager, covering Kericho County and Bomet County. I also am also part of the internal auditors team in the company. Our topic of discussion today is around quality cost. In simple terms, we are talking of what is the cost that is attached to quality services. Giving a service is one thing, and giving a quality service is something else. So when you decide as a requirement or otherwise that you are going to give top-notch quality services to your clients, you must also be cognizant of the fact that these quality services come at a cost. And today we are just going to explore some of these areas that are actually arise in terms of costing when we are talking of quality service, because we need to understand and we need also to convince or to relay this message to our management through the yearly review meetings, for them to also understand that for a quality service, there must be a cost that is attached to it. And it's not a luxury. Quality services is not a luxury, okay? Because you then ask yourself, what is the consequence of not giving this quality service? Okay. So when you look at this cost, we are looking at the cost that we incur when we want to ensure that our services are up to date or are top notch, vis-a-vis the cost that you will incur when there are consequences that will arise from the services that you have offered that are not of quality as such. So our outline today for this discussion, we'll be looking at the introduction to quality cost analysis. And for the purposes of this discussion, quality cost analysis will be abbreviated as QCA. When you hear me talking of QCA, what I'm just referring to is quality cost analysis. Then we will also be looking at the classification of quality costs. How do we then classify these costs that arise due to quality? Then number 3, we'll be looking at measurement and data collection. Measurement of what? Measurement of the costs that are actually aligned to quality provision, quality service provision. And where do you collect data from? So we'll be looking at such like things. Then we'll also be looking at analysis of the data that we have collected and interpretation of that data. How do we interpret this data and how do we utilize that data in terms of management or in terms of decision making? Then we also look at management implications of QCA, management implication of quality cost analysis. Does quality cost analysis have an implication to management in terms of decision making or such? Then we will also be looking at the benefits of implementing quality cost analysis. Does quality cost analysis have any benefits? We'll be having a look at that as we proceed. Then we look at what are the challenges in terms of coming up with an effective quality cost analysis, and what are the limitations of quality cost analysis, because anything or everything has its cons and pros. So we look at the challenges and the limitations of quality cost analysis in terms of service delivery as such. Then finally, we look at the strategies for effective QCA implementation, strategies for effective quality cost analysis implementation. So colleagues, I know being medical laboratory technologists, medical laboratory officers, service providers, we dealt with mathematics in one point or another. So we'll be looking at the simple aspects of mathematics here and there and some ratios here and there, so that those ratios, interpretation of those ratios is very important as such. So introduction to quality cost analysis. When we talk of quality cost analysis, what really comes into our mind or what comes into our head? Quality cost analysis is a systematic identification, measurement, and evaluation of all costs associated with ensuring and maintaining that the desired level of quality in the lab's processes and outputs. When you talk of ensuring and maintaining the desired level of quality in laboratory processes and outputs, we are talking of quality service provision. There is a cost that is actually aligned to or attached to these processes of ensuring and maintaining the desired level of quality as such. So the process of identifying these areas, measuring these areas, and evaluating or interpreting the impact of these areas is actually what we call the quality cost analysis. Each step in the lab, each process in the lab has an aligned cost on that process. So when we look at identifying these processes, measuring the cost attached to these processes, and evaluating the impact of the cost that is attached to these processes, we call the entire of that process as quality cost analysis. So in summary, it encompasses both the cost incurred to achieve quality and those resulting from poor quality. Those are costs. When we'll be classifying costs, we'll look at that. The cost that you put in all the way from the moment the sample comes into a lab, or even before, because we have services that come before even sample collection. Okay, so it encompasses the entire process, costs incurred to achieve a quality outcome, and those resulting from when you give a poor quality output. So it covers both. So in essence, the cost of quality is not the price of achieving excellence, but rather the total cost of ensuring that quality is achieved and maintained compared to the cost of failing to do so. I was just having a discussion with somebody, and he pointed out that if you think quality is expensive, then evaluate the consequences that arise from not giving a quality result as such. What consequences? Look at the litigation areas. Look at the patient complaints. Look at eroded reputation for your facility. Look at the lost clients because you gave a poor quality outcome. So when you look at this, you are looking at the total cost, ensuring that the quality is achieved and maintained compared to the cost of failing to actually adhere to the quality standards. So the importance of quality awareness in laboratory quality management is very clear, very important. In clinical laboratories, where quality directly influences patient safety, diagnostic accuracy, and operational sustainability, awareness of quality costs is essential. If you have set quality standards in your lab, and you have said that you are going to ensure that the quality assurance processes that you have put in place have a direct impact on the patient results, then you must be aware of the quality costs. You cannot run blindly, because quality costing is very important, because this quality costing, it will even help you when deciding on the cost of a test. Very important, because there are processes. That is why you find that a lab A is charging for a service at 500 shillings, and a lab B is charging for the same service at 3,000 shillings. And you wonder that the clients actually appreciate what is being offered at 3,000 shillings. Why? We'll be looking at that. Because this facility B did not just come up one day and decide that, yes, my price is 3,000. No, there are these evaluatable variable aspects that were looked at, including quality, cost, to decide the price that was settled on as such. So in short, when we look at quality costing, it enables management to balance quality performance with financial responsibility. Quality must match financial responsibility. If you find that the financial responsibility is higher than the quality input, there is a problem. Okay? It has to be balanced. The more quality you put in, the more financial output is anticipated. That is why I was just alluding to the fact that you find that it also raises the cost of service as such. So cost tracking, when you track your costs, it reveals areas where waste or insufficiency occurs, such as repeated testing, reagent wastage, or downtime, and guides corrective actions. When you track your processes, when you assign a cost on each of those processes, and you identify those areas where wastage or insufficiency is occurring, you identify those areas because you ask yourself, for example, what is the cost of repeating QC? And who covers that? What is the cost of patient sample retesting? And who covers that? Yes, your SOP indicates clearly that for very abnormally high or abnormally low values, you will repeat testing before you release those results. Okay, just to be sure. But then that is the SOP. It has said that you, as the financial planner of your lab, ask yourself, where is this cost aligned to? When you repeat that testing, how do you account for the costs that are aligned to that repeat testing? How many repeat testing do you do in a day? For example, if you find abnormally high values across 15, 20 clients in a day, where do you assign that cost? That is something that needs to be looked at, because every process must have an attached cost. Once you understand the attached cost to that process, then it becomes very easy to determine, because then your area of focus will be trying everything possible to ensure that your processes are top notch so that you do not have those repeat costs as such. So by quantifying the cost of poor quality, and the cost of poor quality for the purposes of this discussion, we'll be looking at it as COPQ. Laboratories can justify investment in preventive measures like staff training, method validation or method verification, and equipment maintenance. How do you convince your management, for example, that staff training, a budget is needed for staff training on ABCD? How do you go about it? That is just rhetorical on my end. How do you convince the management that you are going to utilize a whole box of kits for method verification. How? How do you convince the management that your hematology analyzer, which is working very stably, actually needs yearly PPM, preventive maintenance? How? You must, the only way you will convince your management to actually adopt to this way is actually quantifying the cost of poor quality. The cost of poor quality arising from staff not being trained, the cost of poor quality arising from methods not being verified, the cost of poor quality arising from equipment not being maintained. So once you have quantified the cost of poor quality, that is what you use to justify as a justification for the preventive measures in laboratory programs. So ultimately, cost awareness ensures that quality improvement initiatives are not seen as expenditures, but are strategic investments that influence reliability and client satisfaction. This point, this last point that I've just read is directly linked to the previous point where I was saying, for you to convince anybody that these services are actually needed, you must have quantified the cost of poor quality. So once the cost of poor quality is higher than the investment that is actually needed, on preventive measures, it means it should be adopted. And once it's adopted, you identify, that is one way of identifying the quality improvement initiative in terms of staff training, method verification, equipment, just to mention a few. So ultimately, the cost awareness ensures that quality improvement initiatives are not seen as expenditures, but as strategic investments that enhance reliability and patient satisfaction. So what is the relationship between quality, cost, and efficiency? This is a very important slide that we need to be aware as service providers, because for those of us without structures in place, it's so hard to convince the management that ABCD is needed. But the previous slide that I've just done and this slide can actually help you pass this information across, or can help you get or adopt some of these processes and put them in use. So there is a direct and dynamic relationship between quality, cost, and efficiency in laboratory operations. Number one, high quality minimizes errors and rework, thereby reducing operational costs. When you invest in quality processes, quality assurance processes, you make sure that your staffs are trained well, you make sure that your methods are verified, you make sure that your internal quality assurance processes are top-notch. It means that you will greatly reduce the errors, be it analytical, pre-analytical, or post-analytical errors. You are reducing them. And when you reduce the errors, it reduces the operational cost. Because when you reduce the errors, it means there will be no repeat testing. It means those results, once they are released to the patients, there are no complaints, there are no lost clients. Customer satisfaction is top-notch. There are no costs that are incurred to solve some of the issues or litigation problems that arise from poor quality. So in short, it reduces operational costs. On the other hand, low quality leads to repeated testing, client complaints, reputational damage, and this significantly increases hidden costs. When you repeatedly test on your platforms, you are increasing operational costs. When we have client complaints about your services, you are increasing operational costs. When there's reputational damage, people will not seek services from your facility. It increases those hidden costs. Then finally, efficiency arises when laboratories invest appropriately in prevention and appraisal measures, leading to fewer failures and optimal resource utilization. Very key when we focus on investing what we have in preventive measures and appraisal measures, this leads to fewer failures and optimal resource utilization. And when we have fewer errors and optimal resource utilization, that directly reflects on efficiency. So the operational principle for quality cost analysis is very simple, and it goes: the more you invest in preventing errors, the less you spend correcting them. It's as simple as that. The more you invest in preventing errors, the less you spend correcting them. A well-balanced quality cost analysis system ensures that laboratories achieve both technical excellence and economic sustainability. Colleagues, in as much as we focus on quality service provision, we must also look at economic sustainability. You can give quality services, but you end up closing that lab of yours because you are not breaking even. So it has to be a balanced way of doing things. The quality input should actually reflect on the pricing of the services that you are giving. That should go hand in hand, because you might invest so much in quality and actually hit a negative in economic sustainability. So we must look at balancing these avenues as much as possible. There is a cost that is attached to quality service, and this cost must actually be factored in when it comes to pricing of your services. So classification of quality costs. How do we classify quality costs? Number one, we have prevention costs. Prevention costs are actually costs incurred to avoid errors before they occur. These are costs that are actually attached to processes aimed at avoiding errors before they occur. Examples: staff training and competency assessment. Staff training and competency assessment, there's a budget that is actually allocated to staff training and competency assessment. That is a cost. There's a budget that is actually assigned to equipment maintenance and calibration. That is a cost. There's a cost that is attached to method validation and verification. It must be factored in. There is actually a cost that is attached to SOP development and documentation control. There is a cost. We must acknowledge that cost. Then there's a cost that is actually attached to internal quality processes, IQC. We must acknowledge that cost. We must be cognizant that, yes, it's not just a process. There is a cost that comes with that process. And it's a cost that is called the preventive costs. These preventive costs, these are costs that you incur, you put in quality assurance processes before the errors actually occur. So that is something that we need to actually understand such. Then number two, we have what we call appraisal costs. Appraisal costs, these are costs that we incur when we are monitoring, inspecting, and evaluating the processes and results. In short, these are monitoring costs, inspection costs, or evaluation costs. In terms of, for example, we want to see how our systems are working well. So we have what we call internal audits. An internal audit has a budget. There's a budgetary allocation to internal audits. There's a budgetary allocation to management review meetings or sessions. They come at a cost. They happen at a cost. So we must be cognizant of this cost. How do we factor in this cost when it comes to service delivery? Then, when we evaluate our QC performance over time, It comes at a cost. Your staff performance evaluation over time, it comes at a cost. When you review results before release, probably in your area of operations, there's a step higher that you need to achieve before you review that result and release. For example, maybe there is a clinical pathologist who need to review that result before it's released. Bringing on board that clinical pathologist, whether it's on permanent or local basis, it comes at a cost. That is a cost that we need to look at. Inspection of reagents and consumables, it comes at a cost. That is something we call the appraisal costs that come around monitoring, inspection, and evaluation of the processes and results as such. And number three, we have what we call internal failure costs. Internal failure costs, these are costs arising from nonconformities detected before results are released. Costs arising from nonconformities detected before results are released. Before you release a given result, you realize that, hey, there was a QC failure somewhere, okay? Or you realize that there's a sparked performance as such. So you need to rework or repeat testing for this process. That cost of repeat testing actually comes under internal failure costs. You find that we have wastage of reagents and materials, pilferage, or we have kits that are not just performing. Maybe you run a kit and you find that the control line does not appear. Then you repeat testing. It comes at a cost. Those are two kits that have gone. How do we account for that? Equipment downtime. How do we account for that? Sample rejection or recollection. Maybe it was an outcall. You travel to somebody's home, household, you collect a sample, you come, you reach the lab, it's hemolyzed, you go back. Okay? Or it has been rejected, you inform the referring facility that yes, we have rejected this sample. They need a recollection. That is a cost that needs to be factored in. So internal costs actually are costs arising from nonconformities detected before results are released to the patient. And they need to be factored in when it comes to quantification of these costs. Then we have external failure costs. External failure costs, these are costs due to errors detected after results have reached the patient. You have released the results to the patient. Then you realize, oh, there's a problem. The patient has already received that result. And this mostly, in most scenarios, these cases usually arise as client complaints. The client or the doctor is complaining about the result that you have put across. It has already reached the client. Or the cost of recalling results. Number two, loss of reputation or customer trust. They already have these results. How do you then? That is a cost. It might not look like a cost, but it's a very significant cost. The cost of investigation of incidents and refunds. That is a cost. The cost of regulatory penalties, the cost of accreditation penalties. Because you are given accreditation based on assurance that your services will be top notch and you cannot do without it. So you have reached to a point that you have given a wrong result to the patient, and accreditation entities are aware, for example, or regulatory entities that came to be aware. What happens? It comes at a cost. So external failure costs, those are costs that actually arise from errors detected after results have reached the patient. And they are the worst. They are the worst kind of costs that you can ever encounter as a service provider as such. So how do we measure? How do we measure this? Number one, measurement and data collection in terms of quality cost analysis. This is the procedure. Identifying quality related costs. And how do you identify the quality related costs? I've just said there are four categories of quality related costs. There are prevention costs, there are appraisal costs, there are internal failure costs, and there are external costs. So begin by reviewing your lab standard operating procedures and quality records to ensure that all potential cost sources are captured systematically. So you go under prevention costs, list all of them, list all the processes that fall under preventive costs. Go under appraisal costs, list all the processes that fall under appraisal costs. Go under internal failure costs, list all the processes that are under internal failure costs. Then under external failure costs, list all the processes as such. Once you have listed, you have captured them systematically, then what follows is quantifying quality related costs. How do we get the data on this? Look at the financial records, procurement invoices for reagents and consumables. For example, if you procured a kit at 3,000, and let's say those kits are 20 in it, so roughly that gives you around 150 shillings per kit. Okay? So at bare minimum, before you put in any other processes, at bare minimum, using the example that I've given, when a kit does not perform well, at bare minimum, you have already lost 150. At bare minimum, before we put even any other process in it. Okay? Look at, for example, equipment maintenance costs. Because when people when service engineers visit, they create service invoices. Look at it. How much does it cost for ppm for your hematology analyzer per year? Document it somewhere. Look at the training budgets from the finance department. How much was allocated to staff training? Put it aside. Go to quality records. Look at the QC failure logs. Look at the rework logs. Sample retested. How many samples do we test? Do we retest, for example, on an average basis in a month? QC failure logs. What is the frequency of QC failure and repeats as such? Reagent wastage records or expiry reports. Onboard on-site expiries. Do we quantify that? Then non-conformity and incident reports that arise from non-conformities or aspects that do not align to procedures. Once you have listed all these processes, at least you have a rough idea of how much is attached to each of the process. Then you move to quantification steps. And in quantification steps, you assign costs to activities. For example, calculate reagent cost per failed test or per repeat test. Calculate reagent cost per failed test or per repeat test. For example, this is very simple. You are creating a reagent, you are being sold at 20,000. That creatinine reagent, you are being told by the manufacturer that it can do 200 tests. So, if it can do 200 tests and you bought it at 20,000, what is the cost per test? That is 100. But then you have not factored in QC out of this reagent. Because if QC, if the total reagent quantity test is 200, probably those tests that you will be doing are around 120. The other 80 will go to QC. Okay, so that is something that we need to be cognizant when we are looking at. So we evaluate our process, then look at the reagent cost per failed test or per repeat test. And the reagent cost per failed test or per repeat test is the same as the reagent cost of test that is successful. That is something we need to look at because the reagent consumed is the same, whether test goes successfully or not. So use standard metrics, for example, percentage of total laboratory budget spent on QC failures. At the end of the month, for example, do you have a rough percentage of total laboratory budget spent on QC failures? You can look at it at cost per sample retested. Of course, this is something that you can work hand in hand with the accounting team or the finance team. Cost per sample retested. Because for me, where I work, I know when I do a sample retesting, I know the cost and how I'm supposed to factor in that cost. Okay? So the cost per training session per staff member. For training sessions, what is the cost that is attached to that? Because you must come up with standard matrices that can actually help us or help you identify and assign this. Then C, you record and track the costs. These are tools and methods that can actually be used in terms of use spreadsheets to track costs by category. For example, and when I talk of category, I'm talking of preventive costs, appraisal costs, internal failure, external failure. Example, you can come up with a spreadsheet that has the date, the test type, the issue category, the cost, and corrective action as such. We can use dashboards to visualize trends over time. For example, e.g. QC failures per month and associated costs that come with that. These dashboards are actually useful for management review and continuous improvement because you can track actually the progressive performance over time. Then quality management system reports integrate cost tracking into CAPA reports, non-conformance reports, and monthly QC summaries. Very important. This actually helps link financial impact to quality issues directly. Quality issue should have a direct correlated financial impact. So that helps us sort that out. So what are the best practices when you are doing this process? Ensure all entries are timely, are accurate, and traceable in compliance with GCLP data integrity principles. Very important. If you want to get an accurate outlook of your investment, there must be timely, accurate, and traceable documentation. Number two, review costs periodically to identify high impact areas for preventive actions. That is something that we need to really focus on because the cost that you incur today could not be the cost that you are going to incur tomorrow. That is something that we need to. So we need to continuously look at these processes and review the cost periodically to identify high impact areas for preventive action. Use aggregated data to support management decisions such as budgeting for training, equipment replacement, or processing improvement. That is very key, and we need to factor in that. So, analysis and interpretation of quality-related costs. How do we analyze and how do we interpret quality-related costs? Number one, evaluating trends and cost distribution. The objective is to understand where resources are being spent and identify recurring issues. When you attach a cost to laboratory processes, the higher the cost, that cost that is the highest will tell you that yes, there is a problem somewhere. We are having so many repeat testing. We are having so many IQC failures. There is a problem. The cost is communicating to you as a service provider. So what happens? You go back to the process that that cost is attached on. You identify that process, you evaluate presence of trends, and sort them out. It's as simple as that. Okay. So the objective is to understand where resources are being spent and identifying recurring issues. And these are the steps: aggregate costs by category. And when I talk of category, this discussion is preventive cost, appraisal cost, internal failure, and external failures. Visualize trends over time. And the amount of money you are spending on processes can actually tell you that there's a trend somewhere. The high cost impact tells you that there's a trend in forming. We are spending so much on repeat testing or on IQC because most of our IQC processes are failing. That is a problem. So you so much then concentrate on making sure that you control this cost. And how do you control this cost? You control the cost by ensuring that the IQC training is done, your staff are deemed competent to undertake those processes. So you visualize trends over time, use line graphs or bar charts to show monthly or quarterly costs per category, identify spikes in internal or external failure costs, which may indicate process problems, analyze distribution. That is something that I've just mentioned in the previous slide. Example, if internal failure accounts for 50% of quality costs, it highlights inefficiencies in testing or QC processes. When there is a higher cost or a spiked cost in a process, it tells you that the processes under that cost are actually the biggest contributors to the failures of your system. So you go back and reevaluate the processes under that cost to make sure that they are in tandem with your expectations. So ensure data used for trend analysis is accurate, complete, and traceable to the source. I said that for you to ensure that the process is actually and accurately depicted, there must be an accurate, timely, and traceable data collection and documentation as such. So determining the cost of poor quality. How do we determine the cost of poor quality? It's simple. Cost of poor quality, these are costs resulting from internal and external failures. I said that internal failures costs, those are costs that are detected from errors before the results are actually given out to the patient. External failure costs, those are costs that are actually incurred once the results have actually reached the end user, the patient or the clinician as such. So by definition, the determining cost of poor quality is equal to the costs arising from internal failure costs plus those ones from external failure costs. The formula is as depicted there: internal failure costs plus external failure costs. So how do you interpret? How do you interpret cost of poor quality? High cost of poor quality indicates that failures are consuming significant resources, reducing overall efficiency. High cost of poor quality indicates that failures are consuming significant resources, reducing overall efficiency. Help prioritize improvement efforts. So when you realize that the failures in your systems are bringing about very significant resources beyond what you had budgeted for, they have a direct impact on the overall efficiency of your service delivery. It's as simple as that. So once you realize, for example, your cost of poor quality is higher than the cost of quality, then there's a problem. There is a problem. Of course, that helps us prioritize improvement efforts. An example is, if monthly internal failure costs, is equivalent to $2,000. Then your external failure cost is equivalent to $1,500. Then your cost of poor quality is $3,500. I said it's a summation of internal and external failure costs. Okay. So how do we then interpret the cost ratios, which is very important? You could miss everything else uko nyuma, but this one is very key, very important. There are several cost ratios that are very significant and we need to look at. Number one cost ratio is prevention versus failure costs. I said prevention costs, those are costs that you are putting in before errors can occur. So in short, they are preventive costs. But on the other side, we have failure costs that are arising from failures. Okay. So this ratio is achieved by dividing preventive costs by the summation of internal and external failure costs. Okay. You have preventive costs, then internal plus external costs. Divide preventive costs by internal, a summation of the internal and external costs. So how do we interpret this? A higher ratio indicates effective investment in prevention, resulting in lower failure costs. For example, I want to use the simplest way. For example, if your prevention cost is 5 and the summation of your internal cost and external cost is 2, that gives you a 2.5. But if your prevention costs are 2 and a summation of your internal and external costs is 5, that will give you 0.4. Okay? So what this actually tells you is a higher ratio, which is achieved when preventive costs are higher than a summation of the internal and external costs, indicates that there is an effective investment. There is a power in investment. Your investment is yielding results. How is it yielding results? Your internal and external failure costs have gone low. Okay? But if your internal and external failure costs are higher than the prevention costs, it means whatever investment that you are putting in terms of preventive aspects, it's not working. That is purely explained that way. Then the second ratio is appraisal versus failure costs. I said appraisal costs, those are costs, we call them inspection costs, monitoring costs, or performance monitoring costs. And these are achieved, this ratio is achieved by appraisal costs divided by a summation of the internal and external costs. This actually helps assess if QC activities are cost effective in catching errors early. So how do you interpret this? Low prevention stroke appraisal spending with high failure costs indicates need to invest more in preventive costs. Okay? So high prevention stroke appraisal with low failure costs indicate a mature and well-controlled quality system. When you invest in prevention, when you invest in appraisal costs, we ultimately require that the internal and external costs should be low, should go low. And when they go low, it means you have a well-controlled quality system. It's as simple and directly as that. So, linking quality cost findings to process performance indicators. The goal is always to connect financial insights to laboratory operations to guide improvement. Steps. Number one, you map cost categories to key process matrices. How do you do this? Look at internal failures. For example, look at your internal failure cause. What process is actually contributing the highest to your internal failure cause? Is it QC failures? Is it repeat testing rate? Then you look at your external failure cause. What process is contributing the highest? Is it customer complaints? Is it THA delays, for example? Then look at your prevention and appraisal costs. What are the staff competency scores? Adherence to SOPs. Those are things that we need to look at when we are evaluating such like things. Then use findings to drive action. Use findings from the above to drive action down here. An example, if repeated QC failures causes high internal failure costs, corrective action may involve retraining staff, reviewing reagents, or optimizing workflow. So depending on the process that is contributing the highest to your category of cost, make sure that the finding that you have come up with, you actually use that to drive your action, your corrective action. And I've given an example. If repeated QC failures cause high internal failure costs, corrective actions may involve retraining staff, reviewing reagents, or optimizing workflow. C, track improvement over time. Now that you identified that QC failure is the problem, and you have decided to retrain your staff, you have decided to review reagents and to optimize workflows, track effectiveness over time. Compare cost reduction trends to improvements in QC pass rates, TAT, or client satisfaction. All interpretations and actions should be documented and traceable, supporting data integrity and audit readiness. This is very key. Once you have identified the problem, institute corrective action to that problem, then track the effectiveness of your corrective action. And the effectiveness of your corrective action can only be determined by cost reduction, because we are talking of in terms of cost here today. So what is the management implications? Using quality cost analysis to support evidence-based decision making. Quality cost analysis, once you have identified your processes, you have attached a cost to every process, you have known your areas that need action, you actually use that data as evidence-based decision making. Okay. Number two, it actually helps in prioritizing preventive and corrective actions based on cost data. Where there is the highest cost, that cost calls for urgency, that calls for prioritization. A process that incurs the highest cost, that is what should be focused on the first thing before you proceed on anything else. It also assists in integrating QCA into management reviews and audits. When you have your yearly management reviews, or when you have your quarterly as such, if you do not have your yearly management reviews, or when you have your audits, try as much as possible to align or to integrate quality cost analysis to your processes to see, yes, you could be doing well, but are we breaking even? How are our processes? How are our failures or our errors or non-conformities actually impacting on the cost of service delivery? And of course, it helps in communicating findings to stakeholders and laboratory staff, very important as such. When you have a cost attached to every finding, when you have a cost attached to every error, it's very easy when it comes to it actually assists in communicating such like processes as such. So what are the benefits of implementing quality cost analysis? It enhances operational efficiency and financial control. I've just said processes that bring in a high incurred cost, those are processes that should be relooked at. Those are processes that call for corrective action. Very important way of looking at things. It supports continual improvement and accreditation readiness. Of course, I've just said a cost incurred on a process can actually be looked as a prioritization aspect and can also be used as a corrective action indicator. The higher the cost, the higher the prioritization, and the higher the need for corrective action. It correlates as simple as that. It promotes accountability and resource optimization. Of course, when you know that such and such process leads to this cost, whenever you undertake such processes, you are accountable for your processes. And it also means that you utilize or you consume your resources in a more cost-effective way. It improves customer satisfaction and trust. Our main issue or our main focus is actually to reduce the cost that is actually incurred on external and internal failures. Once you reduce the cost or you control the cost that is attached to internal and external failure costs, it means that your preventive and appraisal processes are working well. And if your preventive and appraisal processes are working well, it means it's effectively impacting on patient outcomes as such. So challenges and limitations for this QCA, of course, there's difficulty in quantifying non-financial impacts. For example, how do you quantify reputational loss? It's quite difficult, and it comes in as one of the challenge and limitation. Inconsistent data recording or cost tracking. If we have some of us who are not recording this data correctly, it means it might give a wrong projection as such, and it might lead to then inconsistency as such. There's limited staff awareness or management support. If you have not been trained in these processes, it becomes complicated for you to use it as such. Then there's need for cross-departmental collaboration, because that's why I was saying that some of these processes, you can only do them effectively if you're working in tandem with the finance or the accounting department, because some you need to get aspects aside. It's not a laboratory aspect only. So that brings in it as a limitation. So strategies for effective QCA implementation: establishing a QCA framework within the QMS, very important. You can actually put your QCA framework in your quality management systems. Train staff on quality cost awareness, very important. For any process that has to be undertaken, you need to train your staff and certify them competent before they undertake that process. So setting cost-related quality objectives. When you come up with quality objectives that have a direct correlation with the cost, it assists as one of the strategies to come up with that. So regularly reviewing cost data during management meetings is very important. You can have a discussion about your data costing during management meetings, very important. You must link QCA findings to continuous improvement plans, very important. These things must work hand in hand as such, because it's very important for them to go together. Colleagues, ladies and gentlemen, that brings me to the end of this discussion. And as usual, I always have a parting shot for us, and it goes this way. Quality cost. Quality has a cost, but poor quality costs far more. Quality cost analysis is not merely an accounting exercise. It is a strategic management tool that empowers laboratories to link quality performance with financial outcomes. By understanding where resources are spent on prevention, appraisal, or failures, laboratory leaders can make evidence-based decisions that improve efficiency, safeguard patient safety, and sustain accreditation compliance. When laboratories invest in doing things right the first time, they reduce the hidden costs of rework, complaints, and reputational loss. Ultimately, the laboratory that monitors the cost of quality is the one that controls its future, delivering consistent, reliable, and affordable diagnostic services in alignment with ISO 9001, 2015, and ISO 15111. 189/2022 principles. Thank you very much, colleagues, ladies and gentlemen. And that is my submission for today.
Thank you, Davis. That was quite insightful, and I'm sure we have learned a lot. We've been able to follow closely, and the presentation was great. So at this point, we are going to get into our discussions, and I can see a couple of comments and also questions. And maybe we can, I want to encourage all of you that if you have a comment or a question, you can still come to the chat box and just put in there your comment so that we can be able to discuss together. So I'll take the first one from Zipporah Momanyi. And Zipporah is asking, who is supposed to carry out this cost analysis? Is it the manager or the QC manager? Back to you, David.
Thank you. Quality cost analysis is a responsibility for both of them, including with, and should work actually with the accounting team. So it's a responsibility of the QA manager and the lab manager and the accounting team. Thank you.
Thank you. Thank you, Zipporah, for the question. And I'm still encouraging all of you that if you have any question or comment, you can come to the chat box and just have your question there. We shall be glad to read it and just to discuss, all of us. Otherwise, it was quite an insightful presentation and quite an eye-opener. So I can see many of you who tuned in have enjoyed the presentation. Stephen Washira saying great information. I tuned in from Laikipia. Then Abraham Lorogoi saying he's tuned in from each lab. I don't know. Okay, LCRH lab. Okay. Thank you, Abraham. And many of you who have found time to join. So I can just see many more comments that are streaming in. And this is from Gideon Kitum saying great, nice presentation. And Amos Wekesa saying great idea. So and I'm not sure that there is any other question, but if you have a question or a comment, you're free to come into the chat box and just bring in your question. Otherwise, I can see many of you are tuned in. Bernard Ocheng saying nice presentation, tuned in from Mombasa. Nancy Tarus, thanks for such an educative presentation. And then there's a question from Cynthia Uma, who is asking, does corrected reports have any cost impact? Back to you, Davis.
What the most important thing is to understand what is being corrected. Is it that you issued a wrong result or erroneous result to the patient, then you are recalling it and correcting it? Now there is where we have a problem, because a corrected report has a direct correlation to either an internal or an external cost, because it could be corrected report before it reaches the patient. But if it's a corrected report that has already reached the patient, then that carries more weight, because if it hasn't reached the patient, you correct internally and release the corrected report. But if it has reached the client, it means that report either has been utilized or is in the process of being utilized for the patient management, which one then will also significantly erode the trust in your services. Because although it's one of the required processes that we have underhand, but it carries significant weight. A corrected report, it means it's an error that was done, and that error communicates a lot to our patients or to our service providers in the end time. So it has to be checked. It comes with a cost. And that's why I was saying there are some of these things that is so hard to quantify the cost that is attached. For example, reputational cost, reputational loss that comes from a corrected report. How do you quantify the cost of that? So it might have a hidden silent cost, but yes, it exists. Thank you.
Thank you for that. I'm not sure there's any other question, but if you have any question, we still have a minute to read your question or to discuss. Otherwise, I want to thank those who have found time to join in. And I can see someone has a concern on CPD points for the webinar that was done on 23rd. So we have not yet been able to upload those CPD points, but they will be done together with this one today. So we kindly request for your patience and also kindly check in at the lapse of 24 hours. We shall be able to upload them together with this. All our staff were able to go on holiday, and as a result, we were not able to upload during the festive holiday. Now, I think we have come to the tail end of this presentation, and over to you, Davis, if you have any closing remarks.
Thank you, Mr. Fred. Just for our colleagues, quality cost analysis is one of the very gray areas that we have been having in our systems. And it's also one of the most lucrative areas now people are focusing on in terms of advancing their laboratory diagnostic careers. It's one of the areas that when you master well, I usually say master the skill to bring unga on the table. This is one of the areas that will really help most of us if you are interested in. And to my colleagues, ladies and gentlemen, just to appreciate you for being here on this 29th day of December 2025. And I wish you a new year, a happy new year in advance, because I believe this will be my last discussion for me in 2025. And I look forward to meeting you in 2026. Thank you, and let's continue learning. Asanteni.
Thank you very much, Davis, for the very able presentation, and also a very, very exciting area that I'm sure is of interest to all of us. And I want to thank you also for finding time for everyone who managed to join this discussion. I'm sure you enjoyed the presentation. So at this juncture, we've come to the very end of today's webinar. And I'll take this opportunity to thank all of you who found time to join in. And as you are in your holidays, or I'm sure you are still in those in the labs or in the medical setups, still offering care, and even those of you who have found time maybe to enjoy the holiday, we want to take this opportunity to wish you a very, very happy festive season, and especially we want to wish you a very, very successful New Year 2026. And at this point, I just want to announce once again that this session was KMLTB accredited and will attract 3 CPD points. And I want to just buffer what I'd said, that the session for the last webinar have not been uploaded, simply because our staff were also on a short holiday, but they will all be uploaded at the lapse of 24 hours together with this webinar today. So don't be worried. At the lapse of 24 hours, just check. You will have received these CPD points. Otherwise, it was a pleasure hosting all of you. And on behalf of Lab Medicine Society of Kenya, I want to take this opportunity to wish you once again a happy festive season and a very, very successful Happy New Year 2026. Thank you, and have a wonderful evening.